Thank you, Dr. John, for this great introduction. I'm grateful to join this great conference. We will start today about maximizing discrimination therapy and efficacy, reducing shock. I think that all cardiologists will deal with ICD, okay, and there is something very important to understand first. To understand first how ICD discriminate between SVT and VT, okay, and how to program. And this, if you do not understand how the ICD discriminate, you can take a wrong decision. For example, if you have a lot of shock and this patient, you cannot discriminate that ICD have inappropriate shock or inappropriate shock for this patient, so can go for VT ablation, and maybe this patient had inappropriate shock. So major function of an ICD, this is four main function. Okay, first, sense appropriate cardiac signal, detect dangerous rhythm variability, provide pacing and defibrillation therapy, and store diagnostic. Programming detection zone. For disclosure, I have most of this slide from Medtronic Academy, and I think the same concept for all manufacturer. Abbott, Boston, and all these things, all these companies use the same concept. Here in Medtronic, he had detection zone, VF zone, and fast VT and VT zone and monitor zone. If we see in this slide, we have VF zone in 320 millisecond, fast VT zone off, and VT off. Okay, these three detection zone and monitor zone available are used to program the therapy, program detection. And we are able to program specific therapy for different areas. Here, ventricular detection, okay, and if we see this window, okay, that they have PR logic and other enhancement. All these things help us to differentiate between SVT and VT. Okay, here ventricular tachycardia, as all we know, and ventricular fibrillation, ventricular tachycardia, regular interval, monomorphic, less susceptible to undersensing than VF, and ventricular fibrillation is irregular interval, polymorphic, more susceptible to undersensing than VT. And we will see now how we differentiate, the ICD differentiate between both. What's meant by consecutive counter in VT zone? Count consecutive interval, as we see 1, 2, 3, 4, 5, 6, this consecutive counter, okay, as there is no undersensing in VT, and apply to VT and fast VT via VT zone. Okay, and we will understand what's meant by fast VT via VT zone and fast VT via VF zone. Okay, and in VF zone, they use probabilistic counter. What's meant by probabilistic counter? Okay, as we see also here, that 1, 2, 3, 4, and then maybe this undersensing, so it continues 5, 6, 7, 8, 9, 10, 11, and there is undersensing, and then 12. Differentiate between consecutive counter before, like here, 1, 2, 3, 4, 5, 6, 7, 8. Okay, here it is the ICD understands that there is maybe undersensing VF zone, so it neglects some undersensing, and the overall it used that number interval needed to detect is set to 18 over 24. So when it reach 18, okay, here he detect the VF. Very different between detection between VT and VF zone. Here, and then redetection after applying the therapy. And what's meant by compound count? Compound count, this if there is a regular cycle length, some VT, okay, or VF that have irregular cycle length, maybe go for VF zone, then the speed is decreased to go to VT zone. So there is combined count between consecutive and probabilistic count, and here VF need interval detected is 24, but in compound count, okay, it decrease, and there is some formula that reach this compound count, okay. Here, if VF counter is 6 from the start, what mean by compound count? It will start, if applied compound count, it will start count 6. If it fall in VF zone, compound count, okay, activate and looks to last 8 beat. If last 8 beat in VF zone, it will activate VF therapy. If last 8 beat in VT zone, it will activate the VT therapy. Okay, what's mean by fast VT zone over VF and fast VT zone via VT zone? Here in Medtronic, that's the only seen in Medtronic company. But in other devices, it have VT1, VT2, and VF. What's mean by fast VT over via VF zone? We can see some patient had a fast VT, but it enters in VF zone. If, for example, if VF zone adjusted to 200 beat per minute, some patient had a fast VT more than 200. It reached 240. So in device, all device will treat this by shock. But if I need, and I am sure that this VT, it is fast VT, and I want to activate ATP therapy, okay, 1 ATP, 2 ATP, 3 ATP, so I can use it via fast VT via VF zone, okay. And the other thing, fast VT via VT zone, okay, it give me chance to terminate or to change therapy on VT only. That if we have here that VT first, if I have 2 ATP and then shock in fast VT via VT, I can use 3 ATP and shock. I can use 1 ATP and then shock. I can use only ATP. The same thing in VT via VF zone. If I have here via VF zone, you see that 240 milliseconds, 250 beat per minute, I can activate 3 ATP. Okay, the device differentiate between the VF and the VT. Okay, concept of ICD technology, SFT discrimination algorithm. We need this in every device to differentiate between SVT or VT. Here we use in Medtronic use some sort of PR logic. It use wavelet, differentiate between EGM. He takes sinus as a template, then differentiate between sinus and VT and VF, and the onset of chamber. Even if had dual ICD chamber of onset atrium or ventricle, and the driving, if drive through the atrium drive ventricle or ventricle drives the atrium, and the stability and the PR logic. Okay, rhythm morphology here. This is normal sinus rhythm. This is ventricular tachycardia. I will take it rapidly. Okay, here his template collection. This match here 82, comparing it with template on sinus, no match 40%. Wavelet operation, how it make deliver therapy or no, if there is more than 3 according to wavelet, okay, it will hold the therapy. If less than 3, okay, it will activate the therapy. Here, how we can program this matches threshold. We can make it 70, make it 80 percent, and auto collection, can it make it auto collection or manual collection? Okay, here SVT limit, it is very important also. I will go and I can choose the EGM wavelet, RV coil to SVC or RV tip to RV ring, anything to match this template. Okay, PR logic, identify and classify the following risk. okay, the rate, the AV distribution, the pattern, the regularity, and finally it will apply all these change and decide how to deal with this arrhythmia as SVT or VT. Very important to see SVT limit, and some patient, what's mean by SVT limit, okay, it's 200 adjusted 260 millisecond. If any tachycardia less than 260 millisecond, the device will intervene with this SVT. It will apply the PR logic, okay, and this very important thing. What's mean by stability also, that stability between the cycle lengths. If there is irregular, some device make consider it as AF. Okay, if regular, it consider SVT or VT. I think the time is finished. The onset I explained. Stability also I explained rapidly, and the high rate timeout. What mean by high rate timeout? That if it's nominally off in all device, that means that if patient has if programmed as on, make 1 minute or 2 minutes adjusted, and after that the device will intervene. It will give shock, it will give ETP, and also without differentiated between SVT or VT. Okay, RV lead noise, that if any noise in the lead, okay, that intervene with discrimination, the device will neglect this. Okay, I think I will finish summary. ICD use SVT discrimination algorithm to differentiate between supraventricular tachycardia from ventricular arrhythmia. ICD use the following discrimination SVT algorithm: PR logic, wavelet, onset, stability. This algorithm use the following aspect to identify supraventricular tachycardia: pattern and rate analysis, difference in QRS morphology, acceleration of the ventricular rate, regularity in the ventricular rate. Thank you. If anyone have any question.
Thank you, Dr. Mohamed. This is a very precise lecture in how to deal or to go depth in programming. والحقيقة يعني محتاجة تركيز يعني، بس شكرا يا محمد، يعني هو وضح لنا شوية. اتفضل يا دكتور ملفت.
Okay.
Dr. Mohamed Bitar from online attendees, he's asking, what is the number of stability in millisecond, 30 millisecond or more, or according to what? This is number one, and we'll add to it, is it changeable between programmable parameter?
Stability in most of device nominally off, as if we have it goes with 30 milliseconds accordingly to clinical coloration. If I see that the device had misdiagnosed AF or VT as a VT, we will change according to clinical parameters. There's no.
Yani you measure what you have in the episode, and accordingly you program.
I will put a program according to what I measure. Why the device misdiagnosed this and deliver therapy inappropriately to AF. If device delivered according to stability, I will make it off. If device misdiagnosed VT as AF, I will program accordingly to our clinical situation.
Okay, Dr. Mohamed Ali from the Egyptian Board of Electrophysiology, he's still in 2nd or 3rd year, is asking, what about if I cannot collect a template?
Actually, it only in most of time template auto collect. Okay, when I collect the template, if I have a clear sinus risk, okay, in my programmer, okay, now I can collect the template. Okay, and another thing, if the patient has apparent conduction, okay, apparent conduction
Meaning left bundle or right bundle or intraventricular conduction delay.
A patient have developed new bond branch flow. Okay, so I can collect template accordingly to clinical situation also. If I will compare between old to template and the new template. If
So do you do template acquisition in every clinic visit
Yeah.
of the patient?
Yeah.
Yes. Okay.
شكرا دكتور محمد.
عفوا.